Neurological Visual Field Effects by Dr. Sujithra H. Dr. Sujithra is a professor and head of Department of Oculoplasty, Amrita Institute of Medical Sciences.
Good morning. Thank you, Dr. Rehana, for including me in this session. So, visual field evaluation is an important test modality in neuroophthalmological examination. So, when to do field test? When the visual loss is there and there is no ocular finding, or if there is neurological disorder that may affect the intracranial visual pathway. To locate the lesion, we need to do visual fields. So, coming to the visual pathway, it starts from optic nerve head, then to optic chiasma. In optic chiasma, the nasal fibers crosses to opposite side and the temporal fibers pass to the same optic tract, and in the lateral geniculate body, the next order neuron starts and the inferior fibers passes through temporal lobe and the superior fibers passes through parietal lobe and it ends at occipital cortex. Here in the visual fields and the retina has an inverted relationship and reversed relationship. The superior field falls on inferior part of retina and the superior field falls on inferior part of retina, and inferior field falls on superior part of retina, and also the right field falls on nasal part of retina, nasal field on the temporal part of retina. Regarding the extension of the visual field, superior and nasal field extends about 60 degree, inferior field is about 70 to 75 degree, temporal fields 100 to 110 degree, and physiological blind spot corresponds to optic disc and it is located 15 degrees temporally in each eye. The automated static perimetry is the commonly used modality, and when fixation loss is less than 20% and if there is less than 30% false positive and false negative response, we consider that as reliable field. The field effect we can get when there is macular problem, optic nerve problem, or any lesion in the visual pathway. If the lesion is in the macular region, it can affect either side, either superior. It won't respect either vertical meridian or horizontal meridian. If it is in the so you can get central scotoma, central cecal scotoma, altitudinal field defect, peripheral constriction of field defect, according to the lesion in the retina. In optic neuritis, you can get either central scotoma, paracentral scotoma, centrocecal scotoma. In papilledema, in early stage, you can get enlargement of blind spot, and in established or chronic papilledema, there is constriction of visual field. So that is an indication of early intervention, early surgical intervention to prevent secondary optic atrophy. In anti-ischemic optic neuropathy, we get altitudinal field effect. When there is chiasmal lesion, we get bitemporal field effect because the crossing nasal fibers are affected. Pituitary adenoma and the craniopharyngioma are the common lesion causing chiasmal compression. And here we can assess the progress of the lesion by assessing the visual field. Okay, here you can see gradually the field effect is increasing, indicating enlargement of the lesion. In retrochiasmal pathway, we get contralateral homonymous hemianopia, If the hemianopia is incomplete, it helps in localizing the lesion. If it is complete hemianopia, that just says that it is an retrochiasmal lesion. It can be either anywhere from optic tract, lateral geniculate body, optic radiation, or occipital cortex. In optic tract lesion, it causes contralateral homonymous hemianopia and RAPD in the contralateral side and bow tie atrophy on the contralateral optic nerve head and temporal pallor in the ipsilateral side. So this hemianopia with RAPD means optic tract lesion. In lateral geniculate body, you can get contralateral homonymous hemianopia, and if there is small ischemia either at the anterior choroidal artery or posterior choroidal artery, we can get sector anopia like this. But this type of field defects are very rare. Coming to optic radiation, the postsynaptic fibers from lateral geniculate body passes as optic radiation. The inferior fibers passes through temporal lobe and the superior fibers passes through parietal lobe. So temporal lobe lesion causes superior incongruent homonymous quadrant anopia, and parietal lobe lesion causes inferior incongruent homonymous quadrant anopia. In occipital lobe lesion again causes contralateral homonymous hemianopia. It is most often congruent. Congruent means the field defect in both eyes are symmetrical, same. When the tip of the occipital lobe is involved, it causes central homonymous field defect. Okay. So it has a dual blood supply, and occlusion of posterior cerebral artery results in sparing of the macular field because it has blood supply from midcerebral artery also. So here in this field we can see the central 5 degree is spared. So it is classical of macular, classical of occipital lobe lesion. And lesion at the tip of the occipital lobe can result in small homonymous scotomatous defect. So here you can see small left homonymous central scotoma. Again ischemia causing right homonymous scotomatous defect. When there is bilateral lesion, it can cause vision loss that is symmetric in both eyes. Okay. So when there is visual field defect, we have to see whether it is reliable or not reliable. If it is not reliable, we have to repeat the field. If it is reliable and abnormal, if it is one eye is involved, that means the disease involving anterior visual pathway. If both eyes are involved, that is the defect and the defect visual field defect respects vertical meridian. The disease involves chiasma or retrochiasmal pathway. If it is bitemporal hemianopia, the lesion is at chiasmal region. If it is homonymous hemianopia, if it is contralateral retrochiasmal lesion, and the lesion is more posterior, that causes congruous field defect. So that's why that's how it helps in localizing the lesion. So here I'm showing a patient who presented with visual disturbance, and her field defect 30-2 field shows central scotoma and 10-2 showed sparing of central 5 degree, so indicating bilateral ischemia of posterior cerebral artery. And this is again a patient who showed spontaneous resolution of optic nerve glioma, and there is improvement in visual field defect too. Thank you.
Thank you. Thank you, Sujithra ma'am.